Good evening, everyone, and welcome to the 2021 Ovarian Cancer Symposium. I'm Dr. Vanessa Alford. I am part of the support team at Ovarian Cancer Australia. I'd like to acknowledge the traditional custodians of the various lands on which we are on and pay my respects to elders past, present, and emerging. It's an honour to be here this evening to open session 3 of this important symposium. This year, we are proud to be presenting a compelling program featuring international and Australian experts presenting the latest developments and advances in the rapidly evolving field of ovarian cancer research and treatment, including genomics, immunotherapy and targeted therapy, and PARP inhibitors. Due to the unpredictable situation with COVID-19, our advisory committee made the decision earlier this year to hold the event virtually over 4 sessions. The 4th and final session will be on Friday morning this week. I'd like to thank our guest speaker for this evening and the panel of the Tumour Board discussion for giving their time to be with us and to share their knowledge and expertise. Thanks also to the advisory group who were instrumental in pulling together the symposium program. Professor David Botel, Professor Anna DeFazio, Dr. Dale Garced, and Dr. Tarek Manyawi. Ovarian Cancer Australia is a national organisation founded in 2001 by people who wanted to provide support to women affected by ovarian cancer and their families and friends. Ovarian Cancer Australia's vision is to save lives and ensure no woman with ovarian cancer walks alone. We are confident that the generous sharing of ideas and expertise made possible by holding events such as these is critical to achieving this vision. OCA offer a range of support services for women and their families, including a support services helpline, telephone and face-to-face support groups, consumer forums, webinars, and our online forum. Additionally, OCA's Teal Support Program is a free national telehealth outreach program tailored to each individual, where specialist ovarian cancer nurses, a psychosocial counsellor, and a social worker support women throughout their diagnosis, treatment, and beyond. Our resources, which provide women with information on diagnosis, treatment, and wellbeing, and our support services are all free of charge, and the resources can be ordered through the OCA website. Finally, I'd like to thank AstraZeneca for providing the funding to enable Ovarian Cancer Australia to hold this symposium. A special thank you must also go to the Ovarian Cancer Australia support team for their hard work and dedication in bringing this event to life. So I'd now like to begin session 3 of the 2021 Ovarian Cancer Symposium. I'd like to invite the chair of this session, Professor Anna DeFazio, to the microphone. Thanks, Anna.
Thank you, Vanessa, and welcome everyone to tonight's session of the OCA Ovarian Cancer Symposium 2021. Before we begin, let me please remind you how to post a question. In the top right-hand corner of your screen, please click on the Q&A tab and you'll see the option to post a question. If your question's already been posted, you can upload the question by clicking on the arrow next to the question. At the end of the session, we'd like to ask everyone to click on the exit link when the session's concluded so that you can be redirected to a short evaluation survey. We really appreciate everyone's feedback to help us plan for future events. So to begin tonight's session, it really gives me great pleasure to introduce Professor Charlie Gooley. Charlie is very well known to many in the audience as a great collaborator and an investigator on a number of projects and clinical trials with our local investigators. Professor Gooley is a medical oncologist and he's the clinical director of the Cancer Research UK Edinburgh Centre. He's also a professor and honorary consultant in medical oncology at the University of Edinburgh. Charlie was the UK lead for the SOLO-1 trial, which led to the first line license for olaparib in BRCA carriers, and the recently reported GOG281 and LOGS trial of trametinib, which is the first positive randomized clinical trial in low-grade serous ovarian cancer. Charlie completed his PhD in ovarian cancer genetics, and his translational research focuses on genomic characterization of ovarian cancer. And tonight, it gives me great pleasure to introduce Charlie to present some of his work on the molecular stratification of endometrioid ovarian carcinoma. Welcome, Charlie.
Right, apologies for all the technical issues. So what I'm going to talk to you about today is molecular stratification of endometrioid ovarian cancer. These are my conflicts of interest. So as you all know, one of the most crucial factors in determining how to treat our ovarian cancer patients is their histological subtype. This is now extremely clear. Histological subtypes identify tumours with different molecular biology, different chemosensitivities, and probably different tissues or cells of origin. And the extent to which these have been classified at the molecular level is highly variable. There's been a lot of work in high-grade serous ovarian cancer. A lot of that has actually been led from Australia. And similarly, in low-grade serous ovarian cancer, the most recent and the largest molecular profiling paper has come from Australia as well. So you've done a lot of work, and I think the same could be said for mucinous as well. So, but what we're going to talk about today is endometrioid ovarian cancer, which has been to some extent under-researched. I'm going to talk to you about a study that we started a few years ago here in Edinburgh, and we've published it in 3 fairly recent papers. But, prior to this, there were a couple of panel-based sequencing studies and 1 whole genome sequencing studies. All these studies had less than 30 patients because it's a fairly rare subtype. And the key mutated genes that were identified were KRAS, PI3 kinase, PI3 kinase receptor 1, PTEN, and beta-catenin. There was a 3% poly mutation rate, which is obviously interesting because of the parallels between endometrioid ovarian cancer and endometrioid endometrial cancer. And there was also a 19% MSI rate in those studies. So what we did, we decided to go back through our Edinburgh Ovarian Cancer database, which is a database that's about 40 years old, and pull out all our tumours that had been called endometrioid of some sort, whether they'd been called endometrioid ovarian or mixed endometrioid and something else, which, as you know, is a label that was given to a few, quite a lot of tumours in the past, but less so now. And actually, we came up with about 500 different tumours, but for a couple of hundred, there was no tumour available. And then we went through them and we did very rigorous path review and applied histological, mandatory histological testing with WT1, P53, CK7, and CK20. And basically, the definitions that were decided upon were to exclude all WT1 positive tumours, any non-endometrioid ovarian histology by current definitions, and any, of course, that had insufficient clinical data. 1 or 2 fell out at the DNA extraction stage. And then we did whole exome sequencing with a target coverage of 100x. And we ended up with 112 WT1 negative cases that underwent this whole exome sequencing. Of these, 69 were grade 1, 17 grade 2, 8 grade 3. There were 3 WT1 undifferentiated cases, which we decided to include, and 15 WT1 negative cases with serous features, which we also decided to include. And we justified that in the final manuscript based on the fact that their mutation profile was largely in keeping with endometrioid ovarian cancer rather than high-grade serous. So when we did a sort of correlative analysis in order to work out which were the most prominent stratifying events, it turned out to be TP53 mutation and beta-catenin mutation. This is the figure with the oncoplot, and also included in this are things like tumor mutational burden, MSI, etc. And the key genes that were mutated were beta-catenin, which is CTNNB1, PI3 kinase, ARID1A, PTEN, KRAS, and P53. So breaking it down, there were beta-catenin mutations in about 43% of cases, PI3 kinase also 43%, ARID1A in 36%, PTEN in 29% of cases, KRAS in 26%, and P53 also in 26% of cases. And when we looked at to see whether they had a significant impact on outcome, beta-catenin certainly did. This is the overall survival and relapse-free survival. The overall survival is a disease-specific survival and as you can see, it's a fairly strong relationship with the beta-catenin mutant patients having a much better outcome and really a very good survival, more than 90% 10-year survival, disease-specific survival. And that remains significant after adjusting for age, stage, and debulking. PI3 kinase, there was no significant difference. ARID1A, there appeared to be a difference, but that didn't survive after adjusting for age, stage, and debulking. And the same was true for P10 and KRAS. However, for P53, again, there was a very marked difference with P53 mutant tumours having a much worse outcome that was significant after adjusting for age, stage, and debulking. What was interesting was that the P53 and beta-catenin mutations were pretty much mutually exclusive. There was only one patient who had both a P53 mutation and a beta-catenin mutation. And the survival curves at the bottom there show the impact of having a beta-catenin mutation in P53 wild-type cases. So if you were P53 wild-type, then having a beta-catenin mutation still predicted a better outcome, both in terms of disease-specific survival and relapse-free survival. So we ended up with this picture where the P53 mutant tumours, perhaps not particularly surprisingly, had a worse outcome and also were correlated with worse features as well, which weren't responsible or weren't entirely responsible for the worse outcome. But so P53 mutant tumours, there were a high percentage that were stage 3 or 4 at diagnosis. It's worth saying that endometrioid ovarian cancer generally is picked up early stage, but if there were P53 mutations, almost half of them were picked up at stage 3 or stage 4. They were fairly frequently incompletely debulked. And they had inferior survival, as we've said, even after correction for these other factors. And they also had high genomic complexity, which is something that's in the paper. I'm not going to talk much about it today. And then on the other hand, you had beta-catenin mutations, where the tumours with beta-catenin mutations, where only 11% were stage 3 or stage 4. And they were frequently completely debulked, obviously partly due to the fact they were early stage. And they had much better survival even after you corrected for these other factors. And they had low genomic complexity. So we ended up with this sort of algorithm that we've called the pristine algorithm. But of the 112 cases, those that were P53 mutant, as we've said, had a very poor outcome. 10-year disease-specific survival was 35%. Of those that were P53 wild type, if they had a beta-catenin mutation, the blue box and the blue line on the survival curve, then they had, as we've said, low genomic complexity and excellent outcome with a 10-year survival of about 90%. And then you had an intermediate group, which were P53 wild type and beta-catenin wild type, and that's the black line on the survival curve. Those had moderate genomic complexity and they had a 10-year disease specific survival of about 60%. And just this, this slide really backs up some of the previous findings. In our cohort, 18% of tumours had mismatch repair defects, and we had a few tumours that also had poly mutations. And in terms of tumour mutational burden, those that had both a mismatch repair defect and a poly mutation were hypermutated, and those are the red bars in the figure on the right bottom. And then there were ones with high TMB. The tumours with high TMB all had either a poly mutation or a mismatch repair mutation. And actually, mismatch repair status did have an impact on both disease-specific survival and relapse-free survival, with the mismatch repair deficient tumours having a better outcome. So that's quite interesting. So that's the section talking about the genomic landscape. And so the main differentiators of outcome are P53 and beta-catenin mutational status. Some endometrioid ovarian cancers do exceptionally well, particularly those with beta-catenin mutations. So there's a question of whether this should affect adjuvant therapy discussions. Some do particularly poorly, those with either P53 mutations or those who are beta-catenin wild type. So the question is, should we treat those patients differently? The cancers with P53 mutations do appear to be real, as opposed to thinking that they're high-grade serous, because many have coexistent endometrioid ovarian cancer mutations. And obviously, there are these potential targets that people are looking at now: MAP kinase pathway, PI3 kinase, P10, ARID1A, and mismatch repair poly tumors potentially targetable with immunotherapy. So it's worth thinking about the underlying molecular biology from that perspective as well. And the other thing that I always wonder is whether we should think about endometrioid ovarian cancer a bit like serous ovarian cancer, splitting it into low grade and high grade rather than grade 1, grade 2, and grade 3. Maybe something we should think about. So just for the last bit of the talk, we also, while we were doing this, we thought, well, it might be a reasonable idea to look at hormone receptor expression in this cohort, because we spent so much effort putting the cohort together that it would make sense to look at this. So we created a tissue microarray that had 3 representative cores from each case. And the tumor microarray was stained for ER, PR, and AR, the androgen receptor. So that's estrogen receptor, progesterone receptor, and androgen receptor. Our favored scoring system here is something called the histoscore, which scores each tumor cell based on the intensity of staining between 0 and 3. And then the percentage of tumor cells that have, say, a score of 1 or a score of 2 is then added up, and you get a number between 0 and 300, with the minimum being 0 clearly and the maximum being 300. And so that histoscore was generated for each case. And these are the numbers. So, you know, if you use the cutoff of 100, then 56% were PR positive, 61% were ER positive, and 13% were AR positive. If you used a histoscore cut of 200, obviously the numbers fell, with 48% PR positive, 30% ER positive, and 3% AR positive. The expression of all of those hormone receptors was correlated with each other, with the strongest correlation between PR and ER. And then when we did hierarchical clustering to identify subgroups based upon hormone receptor expression patterns, then this is what came out, with essentially PR high being to one side of this taxonomy, and PR low on the other side. And then also subsets based on whether they were ER high or ER low. Androgen receptors contributed little to the model due to the generally low level of expression. And so the PR high group appeared to comprise a greater proportion of endometrioid ovarian cancers with grade 1 histology, with early stage disease, and with wild type P53 expression. However, when you corrected for multiple testing, because remember we're testing for 3 markers, then these associations fell out. But of course, it may well be able to demonstrate that this relationship actually exists if you had a set that was bigger than 100, which is the approximate size of our set here. And then what about outcome? Well, in multivariable analysis, the PR high subgroup had a superior disease-specific survival to both the PR low groups. So that's PR negative, ER negative, and PR negative, ER positive. So it seems that PR expression is significantly correlated with outcome, both in terms of disease-specific survival and relapse-free survival. And something else that was quite interesting is that because our database has weights and heights and things, we're able to look for a correlation with BMI. And it turned out that the ER high tumors, ER high endometrioid ovarian cancers, had a significantly higher BMI than the ER low endometrioid ovarian cancers. And for comparison, the ER low endometrioid ovarian cancers had the same BMI as high-grade serous ovarian cancer. So that was quite interesting, because when you think about endometrioid endometrial cancer and the association with obesity then it suggests that at least for the ER-high endometrioid ovarian cancers, there may be a similar association on the ovarian side. And so just the last thing, the last question we addressed, and this was published just a couple of weeks ago, is whether we could then take these molecular and hormone receptor defined subgroups and integrate them. And so in the figure on the left, where we looked at ER negative and PR negative, and then PR negative, ER positive, PR positive, ER negative, and then PR positive, ER positive, what we found was the PR positive subgroups had many more of these beta-catenin mutated tumors, which are shown in the blue, whereas the PR negative tumors had much less of these and far more of the P53 mutant tumors, which are in the red. And in fact, if you look at the two figures on the right-hand side, this shows us quite clearly, because the middle figure is beta-catenin mutation, and you can see a stepwise increase in beta-catenin mutation as you move from PR negative, ER negative, to PR negative, ER positive, to PR positive, ER negative, and then to PR positive, ER positive, which is the highest percentage of beta-catenin mutant tumors. And then if you look at P53 mutations, the steps go in the opposite direction, essentially, with the PR positive tumors having very few P53 mutations. So essentially, PR high subgroups were highly correlated with beta-catenin mutations, and PR low subgroups were highly correlated with P53 mutations. And this was confirmed when you looked at the other way around, when you looked at the genomic subgroups, and then you looked at the PR and ER histoscores. And these violin plots show that the PR histoscore is very low in the P53 mutant, and well, sorry, perhaps best put, the PR histoscore is high in the beta-catenin mutant tumors, and the same really for the ER histoscore. And so that left us with a sort of integrated model that had the best outcome patients being any PR high patients. And then the worst outcome patients were PR low, P53 mutant. And then with an intermediate group, which are PR low and P53 wild type. So just to conclude, so we've got this picture where PR high tumors are largely also beta-catenin mutant, they're low grade, they're high stage, and they're of good prognosis. PR low tumors are more often advanced stage, and if also associated with P53 mutation, they're associated with poor outcome. The PR low, P53 wild type tumors have an intermediate prognosis. So, how can we actually factor this into our decision-making process when it comes to thinking about how to treat these patients? Well, of course, part of the issue is that these tumors are actually quite rare. So they come through our multidisciplinary meetings or our tumor boards, as you might call them, very rarely, or well, I guess maybe, in an average center, you might get between 5 and 10 a year. So it would be useful to validate our findings in the first instance. But perhaps these kind of molecular or hormone receptor features might be most useful when we've got a borderline case and thinking about adjuvant therapy, such as stage 1C, grade 2. And actually, we had an example just last week where we had a patient who, for one reason or another, hadn't had her lymph nodes resected, and she was a grade 2 tumor endometrioid. And one of my colleagues was asking, well, should I offer this lady adjuvant chemotherapy? And, maybe this sort of model would help risk stratify. Obviously, a bit more validation would help. I guess the other thing I would say is P53 status is, generally speaking, very helpful in ovarian cancer treatment decision-making. It's now something we are asking for in all of our ovarian patients. And if there's any degree of equivocation about the immunohistochemistry, then we're asking for sequencing. And that can also be helpful discriminating high-grade serous from low-grade serous. And then I just come back to this other question about whether we should be thinking, kind of trying to dichotomize endometrioid ovarian cancer into low-grade and high-grade, maybe factoring in some of these other factors. So I'd like to thank all the patients who donated samples and all the people who did the hard work, mostly our collaborators from Edinburgh. and I pick out Rob Hollis, Barbara Stanley, and John Thompson. So thank you very much for your attention.
So Charlie, thank you so much for an absolutely beautiful talk. I think it really exemplifies how important it is to look at each of these subtypes differently, because of clearly the endometrioid subtype's so different from our other subtypes. So thank you. Now I'll wait until I have some questions come through, but in the meantime, I've got a couple of questions for you. With those differences in the endometrioid, with those different subtypes, do you think it could reflect a different cell of origin? What is it that you think might underlie those differences?
Yeah, that's a good question. Of course, oh, sorry, there's a bit of a microphone. I think it'd be useful to do, I guess, some single cell sequencing to try and work that out. I mean, I have to say, I've got a very, basic model of the cell of origin for ovarian cancer, and obviously endometriosis is felt to give rise to quite a lot of endometrioid. We have been looking at concomitant or synchronous endometrioid ovarian and endometrioid endometrial, and we think they're mostly these beta-catenin mutant ones. And we've also been trying to look at the cases that are synchronously diagnosed with endometriosis, and we also think these are the low-grade beta-catenin mutant ones. So I guess the question is whether the p53 mutant, more high-grade ones, have a different origin. I couldn't, I would be just guessing if I said which cell I thought that might be, because we do believe they are different from high-grade serous. And as you know, Anna, there's still quite a bit of controversy about whether all high-grade serous come from the fallopian tube or not. So I don't think I could, I think there's recently been a very good single-cell paper that came out of Oxford that was focused on high-grade serous. And I think a similar sort of analysis would help to identify that, yeah.
That's good. Now, there's a couple of questions. I've got one other for you before we go to the participants' questions. So some of the patients do quite well, but do you think that's to do with the biology or response to treatment? Like, what do you think the response to carbotaxol treatment really is in the endometrioid subtype, especially given, they don't have HRD, so what's your thinking about their response to platinum-based chemotherapy?
So my gut instinct is that this is largely related to the biology and not related to chemo. In fact, something that we must do is we must look at how many of these patients actually got chemotherapy. Actually, it's in some of the supplementary data, but we need to look at it in a bit more detail, because I suspect a large number of the beta-catenin mutant tumors, because they were mostly early stage, would not have had adjuvant chemotherapy. Some of them will have, but so I think it's very unlikely that their very good outcome is related to chemosensitivity. I think it's more likely just indolent biology. And then at the other end of the spectrum, you've got the p53 mutant and high grade, who, just inherently we would suspect might have a better response to chemo, but their poor biology is driving their poor prognosis. So that's my gut instinct behind all that. Yeah.
Thank you. I've got a couple of questions here. So one from Dale. So thank you, Charlie. Were there mutational signatures or expression signatures that were unique to the TP53 beta-catenin wild-type tumours?
So we've not, so can you just say the last bit of that again, Anna? Were there
mutational signatures or gene expression signatures that were unique to the P53 wild-type beta-catenin wild-type tumours?
Yeah, so we've not actually looked at mutational signatures yet. And actually, we've not done any expression analysis yet. So this was all done from archival paraffin-embedded sections. Of course, you can do gene expression from them, and we could do mutational signatures from our data. So that is something that we should do, but unfortunately, we've not done it yet. Yeah.
Mm-hmm. And a question from Debbie Marsh. Did you look to see if there were any differences in behaviour between loss of function versus gain of function TP53 mutant?
So
Tumour.
we didn't have enough power to work that out, because there were only, in this cohort, there were only, I think, 19 or 20 P53 mutant tumours, and so we didn't really have enough power to look at the different outcomes. Unfortunately, so we need a much bigger data set. And I know that Australia, you guys are very good at collecting tumours, and you may well have a tumour set that could be used to validate some of these findings and actually help us get a bit more power. Anyway, if anybody does, I would be very open to them. Drop me an email and see if we could try and do some validation or increase the size of some of our cohorts. Yeah.
Mm-hmm. Yep. Might take you up on that. Here's a question from David Botel. People have puzzled over the place of fertility conserving surgery and avoiding chemotherapy for early stage, especially 1A cancers, even clear cell. What's the thoughts about stage 1 and 2 beta-catenin negative in young women?
So stage 1 and 2 beta-catenin negative. Beta-catenin positive. So they're more likely to be these ER high, PR high. So, I guess it's kind of analogous to the low-grade serous situation, where I've got a bit of anxiety about fertility-sparing surgery in low-grade serous and other manoeuvres that might at some point expose the woman to high, high circulating hormone levels that might drive any residual tumor cells to grow. I would always have some anxiety about that, but the way I deal with this style in the clinic is that I talk to patients about the uncertainty. I think given that the outcome, generally speaking, is good, that has to be factored in. And if they really want fertility, then you have to really think about that. There's a grey area around about the fact that if there were any residual dormant cells, that they could potentially be driven by high hormone levels. So you'd have to say we've got a little bit of a question mark about that we can't quantify for you. And so I think in early stage, I think it could be considered. I think there are risks. They're probably small, but that's a little bit of an assumption. But I think it's probably reasonable to consider it in that group. Yeah.
Okay. Well, thank you. Look, thank you again for persevering, and then for a fantastic presentation. I think one of the things that COVID's taught us is we can have you here on the line. It's really been such a great pleasure to have you come and present today. So thank you very much, Charlie.
Thanks very much for the invitation and for your attention. Thank you.
Thank you.